How do I determine if my business will be successful?
This is a complex question. People often write up entire business plans behind this question. To me, it comes down to three main things. Number one, population density and demographics. Is there a disease here? Are there sick patients? Or does everybody in the city bike to work and eat kale? One of my OBLs is in a city with one of the highest rates of diabetes in the nation. It's a good place to find patients to treat. I also have another which is known for its healthy population. So I've had to change the marketing strategy between the two and focus on different types of procedures for each type of location. There are a lot of procedures that may not work in one location, but work in the other one. Another huge factor in success is independence of the physicians around you and of local insurance networks. You need to ask the question, are most physicians surrounding you who are going to be the source of your referrals employed by large hospital systems? And you need to ask, how many commercial insurers are there in this locale? Having physicians who are free to refer outside large hospital networks makes it easier for you to gain patients in an outpatient setting. It makes it easier for you to survive. Physicians employed by health systems often feel pressure to send patients within their own system, even if there's a savings to be had by sending it externally to your facility. Additionally, there are cases I've seen where there may be one large dominant commercial insurer in the area who's incentivized to support a particular health network. And that insurer could exclude you from contracting by closing off their panel and not letting you have access to their patients. Another reason that's really important to consider is the presence of competing office-based labs. Now, it's often a good sign if the local climate is favorable to office-based labs and outpatient practices if there are multiple competing labs. But at the same time, there can be lots of hurdles for competition, especially if all these labs are clustered near your potential facility.
So Dr. Dipple, a lot of early career docs want to know, how will you know if your area will support an outpatient-based lab, and how do you know if it's going to be successful?
Well, I think that with an OBL, the bigger question is if you're going to be doing this on your own or going against a hospital, you're going to have to be able to take on that competition. And that may be a problem in some areas. And so I think it's area specific. If you have a non-compete clause or you have a big hospital system that's not going to refer you patients if you leave their facility, that could be an issue. So I do think there are some potential limitations. On the other hand, if you're in an area where the patients will follow you and go wherever you go, I don't think it's going to matter as much whether the community is able to support. It's more if the patients are able to come and follow you. And so I think that's the biggest key, is who controls the patients. I know there's some cities where there are several large healthcare systems, and they own all the primary care doctors, and they tell the patients where they're going to go. And if you're outside of their network, they're not going to allow the patients to follow you. So I think that's a big consideration.
Since you're out in the Midwest, do you think it's a hospitable area for OBLs?
I think it is, because I think people are more open to the concept. But I can tell you there are several large cities in the Midwest that have very, very large controlled healthcare systems, and that would be difficult. I think in some of the more rural, smaller towns, it's much easier to do. So yeah, I think it's very, very doable in the Midwest.
So Dr. Tejera, tell me, how do you know if your local area is going to support an outpatient-based practice? How do you know if it's going to be successful?
So that is actually sometimes a very difficult question to answer, because quite frankly, what ends up happening, I think, on a lot of these things is it depends honestly on where you work, what type of income requirements you have, and what kind of financial liability you have. So for instance, I practice in a very rural area. I'm, a dinosaur, solo vascular surgeon in a rural area that does a large volume of limb salvage and complex venous disease stuff like iliocable stuff. In my area, if I was saying that I needed to be a top 10% income earner, this would not be viable, right? It simply wouldn't be. If I'm willing to accept having a median income despite running an OBL and the financial risk inherent in that, it's more than viable. And in fact, we've thrived for 11 years doing that. I think a lot of it depends on your clinical practice composition, your payer mix, and what your geographic area is. And then you have to couple that to, again, what your own personal income needs are and what kind of resources you're willing to commit to it. So I don't know that they're easy answers. I would say as a baseline metric that I sometimes give people when they ask me that is, I think if you are average busy, whatever that is defined for your subspecialty, whether you want to talk cases or RVUs or patient encounters, you need to look long and hard at this. If you are low busy, you probably aren't going to be able to support it if you're going to do the financing yourself. And if you're high busy, I always throw the caution out there. People oftentimes look at a one-to-one transfer of things they do in the hospital to the office. That will not happen for most operators. And you would be surprised, depending on the complexity of the work that you do, at least up front, what that drop will be. Now for me, it wasn't a big drop because as a surgeon, I have a little bit of, for lack of better terms, flexibility on this. If I break something, I just admit them to the hospital and fix it. An interventional radiologist or an interventional cardiologist might not have quite that same ability. So my personal case transfer was about 90%. From the hospital over to the OBL environment. And in fact, that's been persistent for 11 years. We do about 90% in our office facility now compared to the hospital. And that also is going to change depending on where you sit in your career. Clearly, somebody who is a little bit less experienced or newer is going to have to be a little bit more circumspect and a little bit more careful about that case selection so they don't get into trouble vis-a-vis what I was talking about earlier about, new fellows going into an outpatient environment. So I think you have to look at what are your volumes, what are your cost and income expectations, and what is your true level of busyness in your practice? Because of course, everybody thinks they're the 95th percentile. And I would encourage people, don't do what I call eyeball accounting. I like to have people metric things, and I like to have people go ahead and create spreadsheets. And I also like to have people then make decisions that are based on hard data so you can actually make a reasonable decision tree.
So, Dr. Gorin, you're up in the Northeast. Tell me, how did you know if your area, whether it's Massachusetts or the entire New England area, could support an OBL? And how would you recommend somebody figures that out?
Sure. Well, there's two different pieces. One, if you're talking about sort of the financial piece of, whether or not it's going to be financially successful. One thing that I tell everybody is don't open an OBL with the idea that will then attract patients and build your business. And OBL is just a good place to work. The patient should still be coming because you're a vascular specialist or an interventional specialist, and you're going to offer care. So for me, I had a vascular practice. So I kind of looked at what I had. I actually planned very conservatively and said about 40% of my interventional elective volume, I was going to move over into the office. And that gave me plenty of volume to support my office-based center. As it turns out, almost immediately I was doing over 90%. And so it was a lot more successful than that. So, you look at build your practice and make sure that you have an adequate interventional practice, and you should be able to do this. But it doesn't take, if you do a day a week and you're doing 2-3 cases, you can really cover all of the expenses of doing office-based care if you're doing it properly. The other issue are the regulatory problems that you need to run into. And that's another important thing to look at. So one of the things we did really early on, because this was new territory in our state, is we had 2 separate healthcare attorneys from 2 different firms vet this and tell us whether there were any legal issues that we were going to run into to be able to do this. And they both came back and said that we were fine. We also worked with a commercial builder and developer who did our addition, who has done surgery centers and knew all of the regulations that were there and made sure that for things like radiation safety and so on, we had all the inspections and things that we needed. And with that, we were in good shape. So I think those are the big two. The last thing, at least in our state, is you do need to be accredited by one of the agencies. We chose Quad ASF in the procedural center category, which is something that a lot of people will commonly gravitate to. And I think that that's a good thing to do, even if it's not required in your state, because it gives you a very nice sort of rubric to make sure that you're, covering all emergency contingencies and that you're beyond reproach in the safety of the care that you're going to give.